Great day to you. I am Madam Yusuf Abiodun, and the title of my presentation is Transfer Bed Mobility and Wheelchair Training Techniques of Paraplegic Spinal Cord Injury Patient. My patient is a 30 years old male diagnosed with paraplegic spinal cord injury due to fracture of thoracic vertebra 9 and spinal cord contusion caused by a road traffic accident 8 months ago. So he's a primary school teacher, and then his felt need include dependent in transfer from bed to wheelchair to toilet, and self-maintenance. So I use a biopsychosocial framework to assess the patient, and I can see that he has some clinical problems. OTPF also demonstrated that the patient has some significant problem related to occupational functions, and then decline factors assessment was done, and prioritization of the problem shows that the patient that would need to start the intervention with independent transfer and mobility up to health management. So the set mobility goal includes the long-term goals that focus around independence in wheelchair transfer, bed mobility, and improved functional engagement in activity of daily living and productivity at work within 6 months. This was later divided into sub-6 sections of short-term goals within 45 minutes of session twice a day for the next 4 weeks. So the patient is expected to engage in transfer strategies. So some of the approaches that could help in engaging the patient include rehabilitative frame of reference, psychosocial frame of reference, and task oriented. So other interdisciplinary team will be helpful to engage this patient, which include physical therapists, prosthetic and orthotic, social worker, and clinical psychologists. All this will be collaboratively worked with in order to achieve maximum best in the patient. The rationale behind the selected activities for the patient is due to the fact that the injury affects thoracic 9 vertebra, which spares some area of function related to the upper limb of this client. So the patient is a known paraplegic patient with muscle of the trunk and lower limb paralysis. So there is little voluntary control of the bladder and the bowel. The patient can actually use manual wheelchair because the upper limb is function, and the patient is a young active man who is willing to engage in varieties of activities and be well productive. So based on these reasons, these activities were selected in order to promote his function and his felt needs. So caregiver education was also deemed important, and that was also looked into. So all this together was activity that the patient was subjected to in order to improve his function. So the selected materials to help in achieving this activity include standard lightweight wheelchair transfer board, bed hoist, and then ultralight locomotion slide sheet, gate belt, commode chair, adapted chair, and hospital bed. So all this together was the instrument that was put together in order to engage this particular patient. So the caregiver education focused around counseling on the early sign of depression, anxiety, psychological symptoms associated with spinal cord injury, and then reduced life satisfaction of the caregiver and the patient. A family training, problem solving techniques, and support group was also recommended for the patient, and education on wheelchair component, wheelchair maintenance, propelling direction, obstacle clearance, and folding and unfolding techniques was detailed to the caregiver. So the following videos indicate the activities participation of the patient and the training techniques. The patient was engaged in bed mobility using locomotion slide sheet, and the patient was encouraged to turn using the slide sheet side to side from left to right, and how the patient can also slide down using the same sheet. Following that, the patient proceeded from supine to sitting posture on bed using the locomotion slide sheet and a body hoist. The hoist serves as a puller where the patient uses upper limb strength to pull up, and the slide sheet can easily be used to drag the patient behind. So bed to wheelchair pivotal independent transfer was trained. So before that, we used to put on the gate belt so that for safety's sake, in order to be able to support the patient. So the wheelchair was, the obstacle part of the wheelchair was cleared, and the patient was taught on how to self-move from a bed to the wheelchair using a transfer board as a connecting object. So from that, the patient will proceed to the next activity, which is from wheelchair to commode. Commode is a special toilet seat that the patient can easily use in defecating. So the same transfer board was used, and the patient was trained on how to pivot independently from the wheelchair down to the commode, and then get probably defecate and return back to the wheelchair. So both activity involve onto the commode and back onto the wheelchair. So we do vice versa. So the patient performed this under a strict supervision and a guidance. So the transfer belt, the gate belt was not in place during the commode transfer because it is meant for toileting. So the patient proceeded to independent wheelchair to chair pivotal transfer using the transfer board as an instrument of connection. So the patient was taught on how to load and unload the body part away from the transfer board. So the initial loading is that the transfer board goes underneath the leg, and then the patient stabilizes the other hand with the hand. So the patient was also taught how to transfer back to the wheelchair. Then how to transfer using a 180-degree movement with the body and with the hoist transfer. So it's an independent transfer that involves the patient self-lifting with the upper limb and turning down onto the chair or the back to the wheelchair. So the patient proceeded to independent and assisted wheelchair mobility training. And how that is done, the patient was taught on how to position the hand at the center of the wheelchair and not behind, in order to reduce fatigue on the upper limb, and also how to clear an obstacles using the back tilt structure. So the patient was given a room to practice this severally, completing 360-degree within the space of the department, and then how to make sure that the hand gets stabilized at the middle part of the wheel rather than pulling the hand behind. So the support staff or the caregiver was also trained on how to support the patient when it comes to obstacle clearance, which is what was clearly demonstrated to them. And the patient practiced this several times within the space of the department. So the caregiver psychoeducation was done by giving a better orientation to the caregiver about the psychological impact of spinal cord injury. So the caregiver was taught on the different components of the wheelchair and how to use or how to assemble and dismantle the wheelchair, the parts that the patient should look out for, the backrest, and how to be sure that the seat is in a good shape, how to clear an obstacles, how to support the patient while propelling. So all this was detailed to the caregiver. And then the psychoeducation also involved the counseling related to the early sign of depression that the caregiver can notice from the patient or from even himself, and how to fold the wheelchair, how to maintain the wheelchair, how to service the wheelchair, where to seek help, where to get support. So all this was emphasized on by to the caregiver. So, and on the last note, all this was based on the relevant evidences that are available. And thank you so much for listening.